On this episode of WarDocs, retired Army Colonel and ophthalmologist Dr. Rob Mazzoli shares his journey into military medicine, the critical role ophthalmologists play in combat, and the evolution of eye protection technology. He emphasizes the importance of vision in combat effectiveness and discusses the complexity of ocular injuries on the battlefield. Dr. Mazzoli emphasizes the importance of damage control in ophthalmology, the need for specialized training, and the challenges of rehab for soldiers who lose their vision. Dr. Mazzoli also explores the future of regenerative medicine in ophthalmology, the transformative role of telemedicine, and the necessity for collaboration in ocular trauma care. For further information about Dr. Mazzoli and our previous guests, visit our website at wardocspodcast.com. Be sure to follow WarDocs on your preferred podcast platform and subscribe to our WarDocs YouTube channel. I'm your host, Dr. Doug Soderdahl, Army Urologist.
Welcome to WarDocs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, WarDocs has you covered.
Today we're privileged to welcome retired Army Colonel, ophthalmologist Dr. Robert Mazzoli to WarDocs. Rob, thanks for joining us today.
Thank you so very much, Doug. It is a truly an honor given the lineup of people that the WarDocs podcast has lined up. I am so humbled to be in that company.
Well, let's start off a little bit with your background. How did you wind up joining the Army initially, and what led you to pursue a career in military medicine?
Sure. Well, I was born in Louisville, Kentucky. My parents are both Italian immigrants, so my brother and I are first generation. And our parents really emphasized the value of education, typical immigrant sort of story. So they really emphasized the value of education and doing well in school. Although we were comfortable but not very well off, and certainly did not have enough financial resources to forecast being able to go to college. So in fact, actually, both my brother and I were fortunate enough to get appointments to West Point, and that's where I graduated my undergrad in 1976. At that time, I always wanted to be a doctor. I always wanted to be a physician. And West Point is not particularly the standard pre-medical route. And I've always actually been something of a nonconformist. So West Point was something of a road not traveled, which kind of fit my personality in any case. But nevertheless, at that point in time, West Point not being primarily a pre-medical pathway, they did nevertheless afford 1% of the graduating class the opportunity to continue straight into medical school. In my class, that numbered about 8 people. And if you weren't in that list of 8, you weren't able to go directly to medical school. I was number 11 or 12 on that list. I mean, may as well have been number 1,200. Chances of going straight in were 0 for me. But there was a secondary pathway to go to medical school, and that was that you had to spend a couple years in the line Army, and then you would become eligible to transfer into medical school while on active duty under either HPSP pathway, or at that point, Uniformed Services University had just opened. It was brand new at the time, so you could go either one of those 2 pathways. So I was commissioned into the Signal Corps in 1976 and did a couple of my the basic training courses for Signal. And I was my first assignment was to the 25th Infantry Division in Hawaii, to the Signal Battalion there. But then I was seconded to the division or to the 25th Division Artillery, where I was the battery executive officer and the commo platoon leader at HHB DeVarty. And I did that. It wasn't too tough being a bachelor in Honolulu or on Oahu. I'm not going to get a lot of sympathy notes for that. But that taught me an awful lot about the Army, the infantry, and putting the leadership skills from West Point to work. I was fortunate enough at that point then to be accepted to medical school, which was at USU, and I was part of the 3rd entering class. The buildings weren't built yet; they were still under construction. The campus was certainly an active construction zone, but it was a heady time because we were really on the in the ground floor. In any case, I graduated from West Point or from USU in 1982 and did a internship at William Beaumont, flexible internship at William Beaumont in Texas. I was interested by that time. I had developed an interest in ophthalmology based on largely based because of a West Point classmate's father being an ophthalmologist. And as you go through medical school, you start saying, "Well, I'm not going to do this. I'm not going to do that." And I was scratching my head. What was it that Dr. Carmichael was doing? Opta something or other. I couldn't even spell it. And for the people listening, ophthalmology is Greek, so we have a couple extra silent letters thrown into the correct spelling. In any case, I developed an interest in ophthalmology. Ophthalmology residencies at that point in time were not taking interns straight into residency. You had to go out and be a general medical officer, and that's what I did for a year. I took a medical command in Korea in Uijeongbu at Camp Red Cloud. And so for a year, I was a small unit medical commander just outside of the DMZ. I was picked up for an ophthalmology residency at Brooke Army Medical Center, which I did from 84 to 87. And my wife was also an ophthalmology resident a year behind me at that point. So after graduation, I stayed on at Brooke as teaching faculty until she graduated. When she graduated, we were then transferred to Fort Benning, Georgia at Martin Army Hospital. And I stayed there for a couple years. At the end of 2 years, I was selected for a fellowship in ophthalmic plastic reconstructive surgery, which I did in Philadelphia at the country's oldest eye hospital, the Wills Eye Hospital in Philadelphia, under the tutelage of Joe Flanagan, literally one of the world's leading oculoplastic surgeons. In one of the Army Great Good Deals, they said, "Oh well, we really don't have to honor joint domicile because education is at your call." So they left my wife at Fort Benning while for the 2 years that I was at Philadelphia, and Delta and I got to be very close friends. At the end of that, of course, that was 90 to 92. During that period of time, Saddam decided to go south. That was an interesting period of time in Philadelphia. My co-fellow was a Naval Academy colleague of mine from the same year, so that both of us were on active duty, but relatively protected against deployment. But we were kind of certainly we had a lot of focus on ourselves during that period of time. That's Bill Bigham. At the end of our time, Bill went back to San Diego and became the specialty leader for Navy ophthalmologists. At that time in '92, the Army had decided to close Letterman, which was where one of our residencies was. And we reestablished that residency at Madigan Army Medical Center in Tacoma, Washington, just to have a presence on the West Coast. We could not leave the West Coast uncovered with specialty care, and so we reestablished the Letterman residency at Madigan, and I was part of that charter faculty there. And that's where I stayed. I was the chief of oculoplastics. In late 1999, early 2000, I became the chair of ophthalmology and the chief. And I held that position for the next 10 years. Certainly, and of course, in 2000, we were all still focused on how many cataracts are our residents getting, what kind of specialty training are we going to pass the RRC, and then 9/11 kind of dramatically shifted that. And I remember being on the phone call with our other residency chairs saying, "Okay, our focus is now going to be completely different. We're going to war." It was something of a different perspective from my location, because being at Fort Lewis, we were the only residency that was actually co-located with a deploying force. So with all the units in I Corps, certainly with the Air Force as well, next door at McCord, we knew that we were going to be essentially our people that we serve day to day. They were going to be at the tip of the spear, and we were going to have a different perspective on combat casualties than our colleagues in San Antonio or San Diego was closed because Pendleton is closed, but or again Washington D.C. because nobody deploys from there.
You said it's a big shift in what you're doing. You're looking at, hey, how can we get cataracts, kind of bread and butter ophthalmology stuff in residency. Now we're deploying ophthalmologists. What is the primary role of that ophthalmologist in a deployed setting, and how is it different from back in garrison?
That's a great question, and it kind of gets to the heart of where we are, right? Let me start answering that question. Maybe if you'll indulge me, a little demonstration. Sight combat is a visual activity. If you can't see, you can't fight. If you can't see, you can't shoot. And in an environment where it is see or be seen, shoot or be shot, kill or be killed, the first person that can put a bullet down range survives to come back tomorrow. So sight is critically important to combat effectiveness. So if you'll indulge me a quick demonstration, I see you wear glasses. Let me have you take your glasses off and ask you now. I don't know what your vision is without your glasses, but do you think you could be effective in firing, with your glasses off? Do you think you could be effective as you are now?
I could probably hit a 5-meter target, but anything past that would be
So even
not great.
even now, even if all you do is lose your glasses, you are somewhat combat ineffective. Let me ask you now to just put a hand up over an eye and just cover your eye. And okay, now how much more effective do you think you would be if you were to lose sight in one eye?
Yeah, absolutely ineffective.
And that, in fact, requires somebody else to help take care of you. So now, not only have you been minimized, but you might also now have impacted the remainder of the unit. Now, let me ask you to hold a hand over both eyes, cover both eyes. Do you like what you see?
Not really.
Yeah, and that's the ultimate impact. Sight is the most precious of our senses, and second only to death, it is loss of vision is the most feared disability, second only to death. More than cancer, more than losing an arm or a leg, more than going bankrupt. It's losing your vision, and it is such a keen and indispensable sense for us. And the eye itself is actually a very small component percentage of the body surface area. It's 0.25% of the total body surface area, but it has an outsized impact. Number one, eye injuries account for anywhere from, in this most recent war in GWAT, from 15 to 20% of all casualties are eye injuries. Moreover, 80% of those eye injuries end up being non-retainable. Now that's a totally inverse percentage for any other injury. 80% of eye injuries end up with medically disqualified. 60% from the Israeli data. So 60 to 80% of any eye injury, many of which are preventable, will end up in total loss of that person to the combat commander.
So tell me a little bit more about, what exactly is the nature of those combat eye injuries? Is it shrapnel getting in their eye? Are they getting shot in the eye? Is there chemicals, some kind of foreign body? What is it that's causing that injury to be so severe that 80% have to, no longer be able to do what they do?
Right. And the eye fundamentally is notoriously intolerant of any injury or even maltreatment. Napoleon's surgeon Percy said something along the lines of, it's all over with that organ, regardless of how slightly the projectile touches it. And so the injured eye wants to die. I mean, it just wants to give up. That's our role in theater and stateside, is to prevent ocular death if we can, or at least postpone it for as long as we can. Now, the injuries themselves are time sensitive. If you've got an open globe, we know that if we delay the repair of an open globe, we lose 2 lines of best Snellen acuity per 24 hours that we delay that. So you could have an injury that would otherwise have a 20/20 outcome, but if you delay the treatment by 24 hours, your best vision is going to be 20/40. You're starting to look at losing your license at 20/50 and employability at 20/60 or so, 20/70 being a lot of low vision definition. So what is it that's causing it? And as you astutely point out, it's all of those things that you talked about. In the Civil War, there's been something of an evolution from late 19th century to 20th century, what we would consider modern warfare from the 20th century and the 21st century. In the Civil War and pre-modern era, it was largely black powder, gunshot wounds, black powder, explosives were large fragments. And if you took a large fragment to the head or the neck or the eye, it was largely fatal. With the dawn of modern warfare, that being really the Russo-Japanese War in 1905 or so, we started to get the high kinetic energy explosives, high energy projectiles, which created a lot of very small fragments. And that's what we've been seeing since the dawn of the 20th century. And in fact, the reality is that even through GWAT, there hasn't really been a new type of injury that we have not seen and documented very well from World War I. Everything that we saw in World War I, we are seeing now. We haven't really seen anything novel in the last war that we haven't seen since World War I. And that is the small fragmentary pieces. Small shards that would otherwise be innocuous to if they impact on your forehead, doesn't cause anything. A lot of these small shards can be stopped by your uniform or certainly by the body armor, but that small milligram weight of high velocity shrapnel that enters the eye is devastating to the eye, and the injured eye wants to die. So that's what we're looking at, is the small shards. Certainly blast energy in itself can cause a significant concussive injury. Without causing open globe injury, it can certainly do a lot of damage to the inside of the eye concussively.
How has our technology evolved to the point where I remember when I was deployed, you'd see pictures everywhere of someone wearing their eye pro and someone not wearing their eye pro, and you always wanted to be the guy wearing the eye pro because, whatever it was preventing those fragments and projectiles from hitting your eyes. How much has the nature of ocular injuries changed with technology improving in eye protection?
The battle for eye protection is an interesting one, and I watched the interview with Frank Butler talking about the challenges of getting TC3 and however much common sense that makes, how much of an uphill battle that was. And it's the same story with eye protection. We have known since time immemorial that combat is a visual thing. And if you look millennia back at any kind of body armor, whether it's the knights in shining or the leather helmets in the Roman legions, they all leave the eye exposed because you have to be able to see. It's not that people weren't aware that an eye injury could happen. If you look at the Battle of Hastings, Harold the Brit fighting against William the Conqueror famously died because he took an arrow to the eye and into the brain and then died. But you can't protect the eye. Henry II of France was in a jousting demonstration, and the lance shattered, and the shard of the lance went through his helmet because of the eye opening. Again, went through the eye into the brain, and he was attended to by Vesalius and Perret, and still nevertheless died. And if you think that's unusual. The exact same thing happened in 2007 to a Renaissance medieval jousting reenactor, where that lance shattered and went in through the eye of the helmet. So we have known that the eye is a portal to damage or even death, but we've not been able to do much about it. Now, there have been a variety of attempts putting little cages, metal screens, slits, narrowing the visual opening as much as we can. But then that obviously has an impact on your ability to see the enemy. And so people are understandably reluctant to put anything in front of their eye that they think is going to decrease their ability. We have known since Vietnam that 2 millimeters of polycarbonate will prevent a lot of these small shards from going in and devastating your eye. But the design left a lot to be desired. There again, it somewhat degraded the optical clarity, and it wasn't until material science caught up with being able to design eye protection with the 2 millimeter polycarbonate that we actually had something that would be effective. Now, having developed it, getting people to wear it was a different challenge. And so again, people say, well, I don't like the design. It makes me look like a senior citizen from a retirement home. So even though they cost like $15 or $16, the military logistics system decided to make it an accountable item. So eye protection was all locked up in the supply room. You had to sign it out, and you became financially responsible for it, and you had to pay for it if you lost it. And it actually wasn't until GWAT. The accepted story is that we started to see photos coming out of theater of the special ops guys, and they had their beards, and they had their guns out, and they had their weapons out, and they had their hats, and they had these Oakleys and Wileys high-speed sunglasses, and they looked cool. And a lot of people started saying, oh, you know what? I want to look like that. Now that's something I'll wear. I want that. And under the Rapid Fielding Initiative, there was a lieutenant colonel, and we can track that name down. There was a lieutenant colonel at Fort Belvoir who said, I will sign off on the ability of units to pay $80 to $100 a copy for Wiley X and Oakleys if they'll wear it. If that's what it takes to get people to wear this piece of effective armor, then it becomes a leadership issue at the combat leader of actually making sure that your people do wear it. All of this design of eye protection can be tracked down to Colonel Frank LaPiana, who was a colonel at Walter Reed, oculoplastics colonel at Walter Reed. He made that. He's the guy from Vietnam who saw that as a challenge and devoted the remainder of his career to getting that done. Bill Madigan at Walter Reed is the guy that actually got it done and over the goal line, and then it became a line leadership issue. Fortunately, we've been able to do that, accomplish that. Now, whether it persists or not is going to be another question. And that's part of that Walker dip. We've made a lot of advances. The question is whether they're going to maintain. To put a point on that, not to extend this conversation too much, but to put a point on that, West Point issues eye protection to all the new cadets in their initial issue bag on our day. But as a West Point graduate, I get the West Point Alumni magazine, and distressingly, it comes out every quarter, and they dutifully will include a lot of photos of the cadets on field training. And in every photo of the cadets in field training, they're all wearing their Kevlar, they're all wearing their body armor, but increasingly fewer photos are showing them wearing eye protection. And that bothers me, because if this is one of the locations where we are teaching our leaders to train the way we fight and fight the way we train, then we are increasingly losing that lesson that we learned very painfully. And if we're not requiring our leaders in training to wear their eye protection, they're not going to know to make their troops wear the eye protection. And we're going to go back to 15 to 20% eye injuries needlessly.
Yeah, let's go back to ophthalmology on the battlefield. So deployed ophthalmologist. Whenever I go to see the ophthalmologist, I go from room to room with these gigantic pieces of equipment that look pretty expensive and pretty fragile. And, they test my visual acuity, look at my, inside my eye and check for pressures. How does that work on the battlefield? How do you get, what you're used to in your clinic? How do you have that same capability to take care of injuries if you need it?
Yeah, it's a great question. We certainly pare down, and something of the evolution of that capability came from our experience in Vietnam through Desert Shield, Desert Storm, and into GWAT. In Vietnam, we were just at the dawn of intraocular surgery, microsurgery, microscopic intraocular surgery. But the expectation of the Vietnam ophthalmologist essentially was going to be very, very large sutures, non-microscopic repair, and primarily enucleation. The sad part of that is that that's the way the deployment equipment set stayed through Desert Shield, Desert Storm. So when Desert Shield, Desert Storm kicked up, we deployed close to 30 microsurgical capable ophthalmologists to the theater, tri-service. There was one operating microscope in theater. For the 25 microsurgeons, we had one operating microscope. There were two others that were kind of makeshift, and it was only by the end of Desert Shield that people started to say, well, I can't do anything with these eye injuries without a microscope. And we tried to get the operating microscopes to everybody, but that was the end of the war. So essentially, we equipped our ophthalmologists to fail in Desert Shield, Desert Storm, and we went back and re-looked at that and said this is unacceptable. So in the interwar years, we re-looked at the equipment set as well as the personnel, and we thought what we need to be able to do is provide in theater the level of care that a medical center would be able to provide. So we were looking to do definitive surgery in theater, and we structured the new eye deployable sets, kits, and outfits to reflect that. So we had pretty much everything that we would need, that we would have at a medical center, we put in the deployment field kit. We also restructured the eye team so that we had a variety of subspecialists, so that we had an anterior segment specialist, we had a posterior segment specialist, a retina specialist, and an oculoplastic surgeon. We had a 3-man eye team, along with equipment that would support them. When this war, after 9/11 came and we deployed our first eye team, what we found is that the surgical microscope didn't fit through the door of the Expando ISO operating room, and it was so heavy that if you were able to shoehorn it into that operating room, then that became the eye operating room, and we couldn't afford to dedicate that. So we found that our best of intent really didn't work in practice. So then we had to go back and start re-looking at some of that. What is it that we absolutely need? As the war evolved, then we also started to say, okay, well, casualty numbers don't really justify having 3 people deployed all the time. Plus, we don't have the inventory to maintain that. And what we ended up doing was deploying solo ophthalmologists and focusing more and more on damage control ophthalmology. Again, part of that was because we had total air superiority, and we could get eye casualties back to the roll 3 quickly and out of theater quickly. But with an upcoming war, looking at peer or near peer or even super peer and evacuation capability, then we probably do have to start re-looking at, maybe we can't just think of a solo ophthalmologist as being sufficient. Maybe a significantly pared down kit is now going to be, again, insufficient. So we do have to take a look at plussing stuff up and plussing personnel up.
So tell me a little bit more about a challenging ocular injury case that you had, and how different it would be treating it on the battlefield versus treating it at a tertiary medical center, and what kind of things do you need looking forward. Like you said, we're not going to have air superiority. Most likely we're going to be very mobile. What kind of things do we need to think about for the future of ocular injury on that battlefield of the future?
Two things come to mind. One is that ocular trauma these days, in the days of subspecialty training, and over the last 50 years, ophthalmology has developed a variety of subspecialists, and they're all very much sui generis subspecialists. We have cornea specialists that do cornea, but they don't do retina. Retina doesn't do peds. Peds doesn't do plastics. Plastics doesn't do glaucoma. Glaucoma doesn't do neuro, on and on and on.
See, I always joke that they have like the left eye guy and the right eye guy.
It gets even finer than that. It's the, okay, well, which not even which micron, not even which millimeter of the eye is it, but
Right.
which micron of
Yeah.
the eye is yours. I'm sorry, I'm a left eye specialist, as you say. I'm only a right eye cornea specialist. But it becomes critical because what we realize is that ocular trauma is really complex ocular polytrauma, because again, the eye wants to die. And I'll use the word complex in the complexity and chaos theory sense, in that it is the butterfly flapping its wings in New York that causes the tsunami in Brazil. And it's no longer just an eye injury that an ophthalmologist can address. It's a cornea injury and a glaucoma injury and a retina and a plastics and a neuro and you need that team of ocular specialists together that can work very often at the same time, simultaneously on the same patient in the same OR, which is what we tend to do with multiple specialties when we talk about systemic polytrauma. And the ophthalmic component becomes a micro focus of that same complexity. It's the lid plus the cornea plus the retina plus the lens plus the glaucoma damage that's the butterfly of that injury that leads to the tsunami of visual loss. We need the facilities that have that team capability, and that's one of the things that we have learned. I'll talk. I think I'll try to talk a little bit about what we've been able to do to try and address that. As far as the individual injuries go, one of the things that I learned is that the majority of our injuries in modern warfare come from blast, and blast never sleeps. It will go to sleep for a bit, but it will reawaken. And when you go back and you try to do something, even if you leave a long period of time between one operation and another, or between the injury and a second and third operation, all you're going to do is reawaken blast. And that means you are reliant on damage control. You don't necessarily want to do definitive surgery at the first intent. And certainly you don't want to do definitive surgery while the injury is evolving. And blast injury takes a long time for it to evolve. And you need that capability. You need that organizational systems level capability to deal with those very complex, evolving injuries. The other thing that you want to do is never shoot a silver bullet too soon. Whatever you think your silver bullet never fails, this is what I'm going to, in this situation, in a non-combat injury, in a motor vehicle accident, and I've always been able to do this technique, and it's bailed me out 100 times. Well, that's not going to work in blast. You're going to shoot your silver bullet, and then that silver bullet's going to fail, and now you're going to be left with some second tier or third tier or fourth tier choice. So you don't want to shoot your silver bullet. If you're deployed as an ophthalmologist, you're focused on damage control ophthalmology, and you certainly don't want to be shooting the silver bullet at that point in time. And more specifically, you don't want to be shooting somebody else's silver bullet. If you're a retina specialist deployed as a general ophthalmologist, you don't want to be doing the big fancy lid flap to reconstruct the eyelid in theater, because that's going to be my silver bullet that I no longer have.
Yeah, I can tell you, later in OIF, the second time I was deployed in 2010, I was actually assigned or attached to the head and neck team, which had ophthalmology, and clearly you don't have that team that you're describing of all the experts of every single part of the eye. So how do you train that ophthalmologist who may be the glaucoma guy, or in our joke, the left eye guy, to take care of when the right eye gets injured? What is the basics that they need to do? You talked about damage control, and I'm a surgeon. I get damage control in the abdomen and chest, but in the eye, what is, you don't pack it, right?
Yeah, and let's talk about that aspect, in a bit. But no, you're right. I mean, the threat to ophthalmology is that we're going to be looking at a staff reduction. Everybody's looking at reducing the numbers, and if we don't have a sufficient number of people that are both capable of doing damage control ophthalmology as well as providing the specialty care, then we're going to lose vision. We are absolutely going to lose vision. So if you're an ophthalmologist, number one, you're a physician first. If you deploy, you have to understand that there are going to be aspects of being in a deployed situation where you're not going to be an ophthalmologist at all, but you're going to be a physician. You may be the triage officer. So you have to know something about everything. Then you're a surgeon. You have to be, as an ophthalmologist, you can't be sitting on the bunk waiting for the eye injury to come in when the OR is being flooded by other casualties. You have to be able to assist you I may not be able to help you in the belly, but I can hold a retractor. I can hold a leg. I can suture. I can cut sutures. I can be a surgeon. Then you're an ophthalmologist, and then you're the subspecialist. And so training a specialist to maintain their general ophthalmology skills is a challenge. And that, I think, is one of the places where simulation does come in. The training courses do come in. I am an ophthalmologist. I'm an oculoplastic surgeon. I've focused on oculoplastics for the last 30 years. It's been a long, long time since I've been on or in an eye. But if I were to deploy, I would be expected to be able to provide state-of-the-art care. There are some fundamental aspects and skills that we need. Suturing the eye is one of those. We can train that in the lab. We can do a certain amount of that via simulation, whether it's VR or mannequin simulation, and damage control. And we, frankly, what we need to do as an ophthalmic specialty is develop the principles, guidelines, and techniques more formally of damage control. What are our guiding principles? Based on the principles, what are the guidelines that augment and clarify those strategic level principles? What now become the strategic guidelines and what become the actual techniques, the tactics of addressing an eye injury. And a lot of it comes down to sealing the eye, providing coverage for the cornea, preventing infection, controlling the intraocular pressure. Those are the sorts of things. Not doing too much.
So, me as a urologist, let's say I'm in a deployed environment, we don't have a head and neck team, we don't have the ophthalmology specialty. What should other surgeons, when they're confronted with a patient, polytrauma, general surgeons, they're, up to their elbows in the abdomen, orthopedics dealing with open fractures, and they're going, hey, urology guy, there seems to be an eye injury up here. What would the expectation be for a non-ophthalmologist in a deployed setting? Should we just stay away from doing anything, or what kind of stuff should we be doing?
Yeah, and then that's where we get into the systems level discussion of zones of care, and that's something that you allude to here. Um, Very largely, in almost any other field of medicine and surgery, we talk about the pre-hospital zone and the hospital zone of care. But for an ophthalmic injury, the reality, as you talk about, only an ophthalmologist is going to be able to do that, to take care of the eye, even for damage control. For if you allow the term definitive damage control. And so what we talk about, the zones of care are shifted to the right for us because now it becomes the pre-ophthalmic zone of care versus the ophthalmic zone of care. And the pre-ophthalmic zone includes the initial hospital level where there may or may not be an ophthalmologist. The pre-ophthalmic zone is everything in front of the first responding ophthalmologist. And as you know, we may have a variety of combat sport hospitals or roll threes, whatever we're calling them these days. We may have a variety of those in theater, but not all of them are going to have ophthalmologists, because ophthalmology is going to be a theater or a restricted asset. So how is it that a non-ophthalmologist at a non-ophthalmic role 3, or the emergency room doc at an ophthalmic role 3, or even at a level 1 trauma center in San Antonio, what do they do while you're waiting for the first ophthalmologist to respond? And in essence, that comes down to do no harm. An eye injury is probably the only injury anywhere else where direct pressure is contraindicated. If you've got an injury almost anywhere else, you're going to try to put as much pressure on there to stop the bleed. But if you put any kind of pressure on the eye, you're going to cause that eye to die even quicker. So our mantra is shield and ship. Put a rigid shield over the top of the eye, no patch over the top, or no patch under the shield, and send that eye as quickly as you can to the ophthalmologist. So, shield and ship, and that has become the doctrine for point of injury care all the way through the first responding ophthalmologist. That's in the TC3 guidelines. Thank you to Frank Butler for doing that. These days, we also have eye shields in the IFAC, so that the first responders, the bystander first responder, can put an eye shield on. And if you don't even have an eye shield, you can take the eye protection, which is polycarbonate, which is anti-ballistic, and put that back over the top of the eye, and that will work as an effective eye shield. So for the non-ophthalmologist, essentially it's shield and ship. Start antibiotics, prevent nausea and vomiting. Anything that's going to cause any retching is going to increase intracranial pressure and CVP and expulse. And for the non-ophthalmologist, probably the most critical aspects are, if it's a chemical injury, don't pass go, start irrigation, regardless of whether the eye is injured or not, start irrigation. Number 2, if there is an orbital compartment syndrome or retrobulbar hemorrhage, do the emergency canthotomy, cantholysis. Shield and ship, start the antibiotics.
So earlier you mentioned, the biggest fear for most people after death is losing vision. So we know that it can be a devastating loss to someone, who's a service member who's young. How do you deal with the rehab of a soldier who loses an eye or literally wakes up blind?
That's an intriguing and still active problem. Uh, as of World War II, the military divested itself from any organic rehab capability. And so vision rehab and blind rehab is the exclusive province of the VA. And so we do not have in-house capability to address that. Now, our OTs and PTs get some cursory training in vision rehab, but that's not what they do day to day, as opposed to the VA that has the world's best vision and blind rehab capabilities. So it is critically important to do interventional blind rehab for somebody who does wake up blind or can't see well enough, and even if it's something as rudimentary as saying, okay, here's your dinner tray. Peas are at meat is at 6, peas are at 10, your coffee is at 2, and this is how you go to the bathroom. This is how you take care of yourself, and that starts to have secondary effects as well on other rehab. If we can't provide in-house vision rehab to a vision, even somebody who might have decreased vision, if the orthopedic rehab strategy for a hand injury is, say, okay, I want you to pick up that cup of coffee with your injured hand with your remaining fingers, and they can't see the cup, that sets their hand rehab back. If we've got our orthopedic leg injured patients on the simulator, and we say walk down this road, or we want you to exercise on this treadmill, and they can't see the treadmill, then that sets back orthopedic rehab. The challenges are that we have a difficult time getting the VA vision rehab people through the gate, since we no longer have that organic capability in the DoD, and we're reliant on the VA. We have set up this barrier where the VA capability can't get on post, and that's something that you think would be relatively easy nut to crack, but it turns out to be relatively harder than we would expect. As we start looking at the overall ocular trauma system, the VA has 13 inpatient, or residential, I should say, blind rehab facilities. And the military has also set up 4 regional ocular trauma centers they were included in the NDAA of 2020 to establish enduring ocular trauma referral centers, and they are essentially at our 4 residency locations: Bethesda, Walter Reed, San Antonio at Brook, San Diego at Balboa, and Madigan in Tacoma. That gives a strategic distribution of critical assets, regardless of which theater that we're fighting. The nearest residential VA blind rehab facility to Walter Reed is up in Connecticut. That's not very close. The closest blind rehab facility to San Antonio is Waco, 120 miles away. That's not very close. Closest one to Balboa is in Long Beach, over 100 miles away. That's not very close. But the closest one to Madigan is 3 miles away at the American Lake VA. So if we're setting up an ocular care system, and we have patients that are blinded, the ocular trauma centers all have identical clinical capability to handle the clinical needs and restorations, but only Madigan has that immediate availability of blind rehab across the street, essentially. And so, if we're looking at referrals and cross referrals, then we should take a look at being able to coordinate those movements.
So there's a lot of interesting stuff going on in the field of regenerative medicine in, all kinds of parts of medicine. What about in ophthalmology? Where is regenerative medicine? I mean, can we grow an eye that we could use to, transplant it to somebody who loses one? What's the status of that?
Very nascent. And the short answer is no, because the eye is brain, and we can't regrow brain. Now, having said that, there is certainly a lot of effort in regenerative medicine. There are, but there are institutes that are being somewhat successful in getting stem cells to regenerate. They've even gotten rudimentary photoreceptor regeneration. Some of our colleagues on the outside are actually getting the optic nerve, which is brain, which is central nervous system. They're getting the optic nerve to regrow, which is phenomenal. But we are we're far away from anything substantial to that. Some of our colleagues are actually doing whole eye transplant. That's exciting. And some have been able to get the organ itself to survive. Now, whether they've actually restored vision through that, it remains to be seen. But getting the eye itself to survive beyond immediate rejection is monumental. So we're taking baby steps. It's a long way off.
One of the other things that I've always been impressed with in military medicine is the ability to reach back and phone a friend if you need it. And that has been helpful for me, in several different cases that are beyond, my specialty level, and in other specialties. How has telemedicine transformed the approach to eye care in remote or deployed environments? And how have you been involved in that?
Boy, and I recently saw your interview with Ron Poropatic as well, because Ron was so critical in helping establish teleophthalmology as well. And yeah, it's been a game changer for us in a couple different ways. One, it allows the forward provider who is intimidated by the eye, whether it's a medic or a urologist, if it has allowed that forward non-ophthalmic provider to reach back to either the theater ophthalmologist or to the worldwide net of ophthalmologists and get a very rapid answer to that. Additionally, as you say, it allows you as the deployed physician to reach back and get an opinion or get a second thought or get some advice. I was caught by a conversation that I had with a Vietnam era ophthalmologist who said that who was assigned to the Philippines, and he was receiving casualties from Vietnam, and he said the most frustrating thing he dealt with was going to bed at night and waking up in the morning with 5 new patients that he knew nothing about. His second biggest frustration was putting those 5 patients on a plane for stateside and never finding out how they did. And when you lose that feedback loop, you lose the ability to grow, to find out whether what you did was right, wrong, or didn't matter at all. How can I be better if I don't know what the outcome was? And that's one of the things that telemedicine allows us to do, is not just reach back as a forward provider and find out what to do, but it allows the stateside providers to give that deployed provider the feedback. And that's why the JTS weekly trauma call has been just so monumentally instrumental in changing the outcomes. In 2011, knowing I had been a part of the weekly JTS calls for many years, waking up at 5 o'clock my time to make the Thursday morning call, and recognizing that as a good idea, we decided it was a good idea to steal a good idea. And so in March of 2011, the Vision Center of Excellence started a monthly ocular trauma call where we actually pirated and parroted the JTS concept of de-identifying the casualties, using it as a QIPI, platform, trying to make systemic changes as well as providing feedback to the theater ophthalmologist to let them know how their patient did. Telemedicine, game changer, certainly going to take an even more prominent role in the future.
Yeah, I mean, you raise a great point about the importance of collaboration with other folks. And one of the things that I've seen interviewing people in WarDocs is that, one things that we find that don't work well are silos. And so we see, service silos of we are doing cool stuff, but, the Army's doing this, the Navy's doing this, or even, with our allies, United States is doing this, the Brits are doing this, the Aussies are doing this. How do we improve that collaboration? And do you have any experience of kind of bringing people together to help forward, what we're doing to deal with ocular trauma?
Thank you for that question. I think one of the things that is a monumental improvement, hopefully, is from I previously mentioned the NDAA of 2020, which established 4 regional ocular trauma centers, and there are criteria that are required as far as the capabilities of those regional ocular trauma centers, and with the intent that those are going to be enduring centers, not to be a silo of excellence, but to provide a system of ocular excellence that then becomes the ocular cog to the joint trauma system or to the defense trauma system, because an eye injury does not exist in isolation. And so, if we develop the regional ocular trauma center capabilities sufficiently, then it does become a seamless cog into the JTS. Now, that also becomes important if we look at the national civilian trauma system. The military has an opportunity to use the template of the ROTCs to export that as a model for ocular trauma on the civilian side, because frankly, civilian side ocular trauma faces a lot of the same challenges that we have answered, and we can provide our expertise and experience, at least, to the civilian side. One of the critical aspects of that, and I kind of alluded to it earlier, and I'll steal the JTS mantra of right patient, of their 5 rights, is that as we build the system and not silos of care or silos of excellence, we need to be able to get the right patient to the right facility that has the right ocular capability at the right time for the right treatment. And it's that right ocular capability that we've been talking about, the complex ocular polytrauma and the availability of all the needed subspecialists. We need to be able to get that patient to the right person, to the right facility. We have not always done that. And that requires a certain specialized knowledge of ocular care coordination that general care coordinators may not be familiar with. And so we need specialized vision care coordinators at those regional centers so that they know real time what their capabilities are. For example, if the deployed ophthalmologist in theater is the solo retina specialist at Brook, let's pick. Well, we have now zeroed out that retina capability at Brook. We probably ought not be sending the patient that needs a retina surgery to Brook for the duration of the time that capability is zeroed out. But the care coordinators should be able to talk to each other and say, okay, we're going to bypass Brook, we're going to go to Madigan or wherever. But you have to be able to do that. We've not done that previously. And the end result was that we ended up with patients that went to locations that did not have the appropriate capability. We kept patients at facilities needlessly when they could have been transferred to other locations that had the exact same capability, closer to home, closer to unit, closer to support. We were ignorant of what those capabilities were. on the far end. So we end up keeping somebody on at Bethesda for an outpatient condition that when the patient was originally from Pendleton. Well, why are we doing that? Well, it turns out that we didn't know that they had what the capability was at Pendleton. So we need that from a systems perspective.
Other than system-wide changes, is there anything that you predict being the next big advancement in either military ophthalmic care or just ophthalmic ocular trauma in general?
Yeah, the big thing that we need is something point of injury that can stabilize the open globe. We need some sort of reversible ocular sealant that doesn't take a lot of sophistication, a lot of skills to apply, and that can stabilize the globe for transport, for delayed repair. That means R&D. And the sad state of affairs is that essentially the sum total of ocular R&D funding is essentially coming from the vision research portfolio, the VRP, the Vision Research Program, which is a congressionally directed pot, and that's been at $20 million for many years. Now, I was on a grant panel once where we funded a single R&D project for $9 million. And at the time, that was more than the entire VRP. And now we've been able to grow the VRP to $20 million, but that's nothing in terms of advancing ocular care R&D. The reality is that, and I'm going to quote Major General Gail Pollock, who said the reality is that our rehabilitative capability for a blind patient these days is, here's your white cane, get in line for the dog. And that's the way it's been since we came down out of the trees, lost our tail, moved into the cave, and the dog came along with us. I mean, the biggest impact, the biggest improvement in ocular vision prosthetics, if you will, has been that we went away from the glass eye because in World War II, the Germans had the silicone and the silica glass that we needed to blow the glass eye, and we went to acrylic. The pupil doesn't even move. And that's been the sum total of the improvement. But literally, biblically, you hear about the blind man with the dog, and we've not changed that. We need to be able to change that. These days we can take an amputee and literally make them Olympic caliber athletes. But these days, our answer for vision rehab is still, or vision restoration, I should say, is still, here's your white cane, get in line for the dog. And we have to be able to change that. That's got to come from R&D investment.
So you've had a distinguished career in military medicine, and we have a lot of listeners who may be considering a career or just kind of on the fence. What advice would you give to someone who's considering a career in medicine, really anywhere in medicine with the military?
Man, do it. And here I'm going to invoke John Holcomb, who is a heck of a role model. You can make a lot of impact, and Holcomb said that he volunteered for everything. I mean, there's a longstanding saying. There's an old saw that says, when you're in the military, don't volunteer for anything. Well, that'll work if you're an enlisted, if you're an E1, if you're a private, that'll work for you. But by the time you pin on the hard stripes, and certainly if you're an officer, that's not going to work. Leadership is not an optional activity in the military. And so if you're interested in making an impact, if you're interested in leadership, the military is just what you need. And you can have such an impact. Even if you don't think you have the authority, you will be able to find somebody who does have the authority. You will be able to cobble the group together like Frank Butler does, like John Holcomb does, like everybody at JTS does. You'll say, okay, well, what problem am I trying to correct? What problem bothers me? Well, who is it that impacts that problem? Well, let me talk to that person. Even if it's a cold call, You can cold call that person, and they will want to address you. So if you want to be a military physician, do it. You can do all kinds of stuff. You meet all kinds of people, truly earth movers, people that fundamentally change the way medicine is practiced, fundamentally have impact on other people, and you'll meet the military community is probably the tightest bond that any of us could hope to forge.
So speaking of earth movers, how would you like your legacy in military medicine to be recorded?
Well, it's not about us, right? Yeah, it's never about us individually, and so you look for the cumulative good. You look for the impact that hopefully will persist beyond your days. If I'm associated with something like with improvement of eye care, I'm happy with that. I don't have to have author credit for that. If I can look back and say, well, the eye shields, and somebody tells me, yeah, the eye shields have been in the IFAC forever, I'll feel good about that. I don't need to say, oh yeah, you knew that it was me. Me and Frank Butler, we're the ones who did that. You don't need that. Just if that persists, then that's good enough.
Well, that's a great perspective. We've been speaking with Dr. Robert Mazzoli on WarDocs podcast. Rob, thanks again for sharing your experiences and insights with us, and thank you for your service to this nation.
Thank you again so much, Doug. Your podcast is providing a very, very valuable resource, and again, it's been my distinct honor, and I'm humbled to have been able to be a part of it.
Well, thanks for joining us. We appreciate it.
Thanks, Doug. Good luck.
Thank you for listening to WarDocs. We sure hope you enjoyed it. WarDocs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team WarDocs on WarDocsPodcast.com. Thank you for your support. If you like war stories and medical drama, WarDocs has you covered. Spread the word.